Hello everybody, my name is Matt, I'm with Scope Education, and here we're going to be talking about Reperfusion AIVR. Now before we get into this lecture, I would love to do a special thanks to today's sponsors, which is going to be rum, ibuprofen, and my favorite friend Celexa for making this video possible. Here's our patient scenario. So you have a 60-year-old male with a chief complaint of substernal chest discomfort. He was working in his garage for several hours and he came inside and sat on his couch. And shortly after sitting on his couch, he started experiencing about the 4 out of 10 substernal chest discomfort. Shortly after, he happened to contact his neighbor who was a cardiologist who told him to call us, 911. When you enter the area, you see the patient is clammy and diaphoretic, and you're going to get some vitals. Blood pressure is 130/70, heart rate is 80 beats per minute, oxygen saturation is 96% on room air, respirations are about 18 non-labored. Patient says that he has no medical history and no allergies, and he took 324 milligrams of aspirin prior to your arrival. While you're on scene, you might as well just do a 12 lead. So this is your initial 12 lead. Pause the video, just take a quick look and see what you guys think of this 12 lead. We're going to go into dissecting it a little bit later. Once you load the patient onto the stretcher and you get into the ambulance, you're going to do a little reassessment and you take his blood pressure again, which is 128/66, heart rate 74, SpO2 is 98, BGL is 86, and respirations are 22 non-labored. At this point, the provider gave 400 micrograms of nitroglycerin and they got a second 12 lead. Second 12 lead is this, and you're fairly close to the hospital, so you might as well just give a little encode, a little heads up, so if you want to transmit this 12 lead. And while you're transmitting this, you notice that the patient goes into a weird rhythm, and you happen to get another 12 lead of that. Now, what's your next step? So how about let's just break it down just a little bit for you guys. Now, please note we don't actually have a previous baseline ECG for comparison, but we're going to break this down regardless. In the first 12 lead, which you can see here, the T waves in the inferior lead, so 2-3 AVF, aren't proportional to the preceding QRS complexes, which makes them hyperacute. If you have an issue with hyperacute T waves, check out our YouTube video, Occlusion MIs. We go over that pretty extensively there. Note that in lead 2, you could fit the entire QRS complex into the T wave, and the T wave in AVL is inverted and possibly showing a reciprocal change. Always remember that the most reciprocal leads on a 12 lead are leads 3 in AVL. These leads are essentially mirrors of each other. At any point, if you see an inverted T wave or ST segment depression in AVL, you should scrutinize the heck out of lead 3 for evidence of ST segment elevation or T wave changes. A cardiologist once said that if you tie off the RCA for fun, the first thing you'll note is a flip T wave in AVL. Additionally, sometimes the only clue to a high lateral MI is reciprocal ST depression or T wave invergence in lead 3. High lateral STEMIs are often very subtle and hard to detect. So as we said, lead 3 and AVL are the most reciprocal of leads. So if you look over here, you have a T wave inversion here in AVL. And then you have some hyperacute looking T waves in lead 3. And if we scrutinize a little bit more of the 12 lead, such as precordial leads V1 through V6, we'll be able to see that there's a lot of ST depression. So V2 through V6, you're going to note a lot of ST depression. We note widespread depression in the precordial leads here. This is pretty interesting. There's no actual ST elevation anywhere on the first 12 lead that we're analyzing now. There is, like I said, notable ischemic ST depression in V2 through V6, and V1 looks slightly depressed as well, but we're not going to hamper on that too much. The ST depression is maximal in V3 and V4, which often represents a posterior STEMI. So if you want to do a posterior, here it is. And you got V7, V8, and V9. Posterior STEMIs are usually associated with inferior or lateral MI due to the RCA or circumflex occlusion. They account for around 15 to 20% of your STEMIs and imply that a large area of the myocardium is damaged. Due to the posterior wall of the heart not being directly visualized by the standard 12 lead that we do, the depression you see is actually a reciprocal change of the STEMI that's occurring on the posterior wall. And if you want to know how to do a posterior STEMI, here you go. Now we're going to do a little quick soapbox. Most cardiac monitors will not display the STEMI message unless there's a full millimeter of elevation. Please don't ever rely on the cardiac monitor computer interpretation. That's the doc in the box. You need to be able to trust yourself and always manually interpret all your ECGs. By learning to identify different patterns and morphology clues, you can detect the earlier and more subtle changes associated with occlusion MI. The great educator All 2 always says that you should never trust the doc in the box. They are written by plaintiff attorneys and it wants you to get it wrong. If I had it my way, I would just take it out altogether. I love the numbers, the QTC and the heart rate and stuff like that. that's pretty decent, but the interpretation from the doc in the box is honestly garbage. So, trust yourself and don't look at that. Be confident in what you do. Now back to the case. When the patient's initial sinus rhythm changed to that bizarre wide complex and somewhat sphincter tone increasing rhythm, he reported a reduction of pain from 4 out of 10 to 2 out of 10. So what do we do? Given the clinical context, we sit back and we observe. We believe this is a case of AIVR, or accelerated idioventricular rhythm, secondary to spontaneous coronary artery reperfusion in the setting of an acute MI. AIVR secondary to successful reperfusion, such as spontaneous or thrombolytics, of an occluded coronary artery vessel in an acute MI isn't often seen in the pre-hospital setting. AIVR typically presents with a rate of 40 to about 120, depending on what source of literature you consult. In the setting of reperfusion, it's usually a benign finding that's free of hemodynamic compromise. It typically self-resolves within a few seconds to a few minutes, and though uncommonly seen in EMS, it's fairly often seen by cardiologists, especially when you go across the pond to Europe. We need to remember that VTAC is typically faster than 130 beats per minute. 120 to 130 beats per minute is kind of the range depending on the literature as well. I typically use 130, and I believe Ryan as well, and it's important to distinguish between AIVR and VTAC. So, the caveat is patients taking antiarrhythmic drugs such as oral flecainide or amiodarone. In these cases, VTAC can be slower than 120 beats per minute. But for the majority of our patients, VTAC is usually going to be over 130. After manually interpreting your ECG and determining that the wide complex tachycardia is less than 120 beats per minute, you should consider the 3 common VTAC mimics. And we went over some of them in our wide complex tachycardia YouTube video, which will link up above. But the 3 most common VTAC mimics are going to be AIVR, hyperkalemia, and sodium channel blocker toxicity. Some ECG manifestations of AIVR include a wide complex rhythm with no P waves preceding every QRS. So scrutinize V1 for P waves, that's going to be your money lead, due to its position over the right atrium. And remember, the ventricular rate's usually between 40 to 120. And some AIVR pathophysiology. In most cases, the mechanism of AIVR appears to be related to the enhanced automaticity in the His-Purkinje fibers and or the myocardium, sometimes accompanied with vagal excess and decreased sympathetic activity. Ischemia, reperfusion, hypoxia, drugs, and electrolyte abnormalities can all accelerate the phase 4 action potential depolarization rates in the His-Purkinje fiber and myocardium, leading to faster spontaneous cell depolarization or enhanced automaticity. When the enhanced automaticity in the His-Purkinje fiber or myocardium surpasses the sinus node, AIVR manifests as the dominant rhythm of the heart. And one big thing we want to hit on before we go back to this case is that we want to stay away from ventricular antiarrhythmics. As the great educator Alma2 says, this is not usually seen, usually does not last very long. The only time it becomes an issue is when it lasts long enough for someone to do a 12 lead, give it to the doc has a panic attack and gives antiarrhythmic drugs. You don't want to do anything. There's actually 2 things you could do. You can either sit on your hands or high-five your patient, because that means they're reperfused, and that's a good sign. If you give lidocaine, amiodarone, and procainamide are all ventricular antiarrhythmics. If these medications are administered to a patient experiencing reperfusion AIVR, you can take away the ventricular rhythm and end up with absolutely nothing. There's a high risk of your patient deteriorating right into a systole. Sit back, pay very close attention to the rate and the rhythm before you administer anything. Always couple your ECG with history, and with reperfusion AIVR, it's best to sit back and allow it to self-resolve. The presence of this rhythm is a good sign. If you're uncertain about and leaning on the edge of VTAC, remember that electricity is a class 1 recommendation by AHA and is much safer than any medication that we carry. Now back to the case. The AIVR spontaneously resolved after a very short duration, and this is the next 12 lead. As we can see, the previous noted depression in V2 to V6 has improved significantly. At this point, the previously shown posterior was obtained. After a few minutes, depression worsened, and depression in V1 through V6, and the patient's level of pain increased. A couple of minutes later, and this happened. The patient once again reported a decrease in pain. Once the AIVR terminated, the ST depressions were noted to have been improved, and this series of events repeated itself a couple more times throughout the transport. In conclusion, the patient was transported to a PCI-capable facility and remained hemodynamically stable throughout the entire ride. Troponin levels were elevated, and the patient was said to have had a non-STEMI. hospital elected to monitor the patient for a period of time, and it's unknown if the patient went into the cath lab. And this is going to wrap up our case study. I hope you guys enjoyed. And like I said, my name is Matt. I'm with Scope Education, and I hope you have a wonderful day.